Good afternoon and welcome. It's my great pleasure to introduce this afternoon's symposium on retinal imaging. My name is Dr. Amy Conn. I've got a wonderful panel with me this afternoon to take us through some of the best cases from the angiogram meeting from 2022 from the Royal Victorian Eye and Ear Hospital. I'd like to introduce Dr. Xavier Fagan and Dr. Ming Li Ling, both of whom who are dual fellowship trained in ocular immunology and medical retina. So it'll help us unpack some of the mysteries of both of those dark arts. Professor Robin Guymer, who is the head of the Macular Research Unit at the Centre for Eye Research Australia and a world-renowned AMD expert, and Associate Professor Salman Qureshi, who's the newly appointed head of the Medical Retina Unit at the Royal Victorian Eye and Ear Hospital, who brings with him a wealth of expertise in imaging and clinical expertise, and he was really the driving force behind this symposium. I would like to read an acknowledgement of country before we go any further. Just to say the Royal Australian and New Zealand College of Ophthalmologists members and participating guests wish to acknowledge the Aboriginal and Torres Strait Islander peoples of this country, sovereign custodians of the country. We acknowledge their continuing presence and the contributions made to the college and the communities we work in. We will respect past elders and communities and will continue to live, work and interact in a respectful manner with present and future elders and communities. The RANZCO Reconciliation Action Plan reflects the messages of its First Nations engagement. The only other bit of housekeeping is that this is designed to be an interactive session, and we have a number of audience polls throughout the afternoon. In order to participate, you will need to download the Congress app, which I'm sure many of you have done already. You'll need to select this session by pressing the little plus button. You'll need to add it to your app, and then if you scroll down to the bottom, you'll see the live polling question section. As we go, feel free to ask us questions. We'll be reserving the majority of the discussion for the end of the symposium, but the audience poll questions will be peppered throughout, so we'd be grateful for your participation. If my clicker wants to work. The origin of this meeting was really that every week on a Wednesday morning we gather to have registrar teaching, and this forms a pivotal part of retinal training at the Eye and Ear Hospital, but is also equally important for ongoing consultant education. We run the full gamut from common things and standard of care presentations, so our registrars really have a great grounding in what's out there on a day-to-day basis, but we also discuss clinical controversies and very rare entities, and we don't always have the answer, but there's always a robust discussion. So we thought we would bring that forum to RANZCO this year. These are our financial disclosures, and without a doubt we do have to acknowledge the hard work of our 3 current fellows who've been instrumental in putting a lot of these case presentations together and really doing the background work. So we'll make a start. The first case is a 19-year-old Chinese gentleman who presents with 2 months of blurred vision in both eyes, but a recent deterioration in his left eye over the last week. This was associated with 3 days of a mild cough and an occipital headache. He really, on systemic review, had no other findings, had no chest pain or palpitation, shortness of breath, no urinary symptoms, no change in his extremities, no paresthesia, and no other constitutional symptoms of note. He'd had no past ophthalmic history, nor past medical history, was on no medications, was a non-drinker and non-smoker. He was born in China but migrated to Australia in 2013, and he was currently studying maths at university while living with his father. At presentation, his visual acuity was 6.9 in the right and 6.24 in the left. He had a really normal anterior segment, no neovascularisation, no anterior chamber cells and no vitritis. This was his colour fundus photograph of his right eye, and I'll start with you, Ming. Can you describe what we're seeing here?
Thanks, Amy. So this is a photograph of his right eye. You can see obvious vitreous hemorrhage that's obscuring the inferior part of his fundus. Interestingly, the arterioles are quite attenuated. You can see the arteriole exiting the nasal retina superiorly. That's really attenuated. He's also got a lot of intraretinal hemorrhage and widespread neovascularization of the superior and nasal aspect of his retina. Very similar but more profound changes in his left eye, again with nearly 360 degrees of neovascularization elsewhere, NVD, vitreous hemorrhage, hard exudates at the macula, You can notice that his optic disc is slightly swollen, and there are ischemic-looking intraretinal hemorrhages at the temporal aspect of his retina. OCT of his left eye was obscured by vitreous hemorrhage, but you can appreciate that in the presence of epiretinal membrane, he's got significant thickening. Thickening of his left macula. His right macula was not thickened, but it is disorganized in the inner retinal layers, which sort of suggest ischemia. Wide field angiography of his left eye shows normal arm to retina time. The arteriovenous transit was also normal, but you can begin to see confluent areas of capillary dropout affecting the temporal periphery, basically pretty much everywhere, but it's very profound in the temporal aspect of his retina. There is widespread leakage from neovascularization at the disc and neovascularization elsewhere, again showing temporal ischemia, nasal ischemia. Oh gosh, it's going, I apologize. Oops. There are similar changes in his right eye with NVD, and profound ischemia.
Thank you, Ming. So now time for our very first audience poll. So if we can open our apps and answer the following question. What do we think is going on? So a 19-year-old gentleman, is this proliferative diabetic retinopathy? Has he had somehow sequential retinal vein occlusions, albeit with a lot of neovascularization? Is this something bizarre like sickle cell disease? Does he have hypertensive retinopathy? Or is this inflammatory or sarcoid? So we should have a poll up that should show us hopefully some responses from you. We get that AV sorting that out. Maybe. So not unsurprisingly, the majority of you would suggest that this is proliferative diabetic retinopathy, which is not unreasonable given his situation. However, we haven't given you all the information. When he went to his GP with 2 months of subacute vision loss, his blood pressure at that point was 211 over 115, and he was promptly dispatched to St Vincent's Hospital, where he was not only hypertensive but found to be anemic and thrombocytopenic. He was in acute renal failure and was treated to fluid overload secondary to this. They commenced him on peritoneal dialysis and was transferred to the nephrologist for a transplant workup. Once his blood pressure was stabilised, however, he was discharged on antihypertensive medications and furosemide, and his aim systolic blood pressure was between 140 and 60. What happened next was interesting. He represented to us 2 weeks later with a deterioration in his vision. He was now count fingers in the right, 6/120 in the left, with worsening bilateral vitreous hemorrhage. A code was actually called on him in outpatients. His blood pressure was 230 over 150, and he was retransferred back to St Vincent's Hospital for stabilisation. Ming, again, if you wouldn't mind just running through the plethora of investigations at this point, just to shed some light on what we think is going on.
So we can all appreciate that he's got profound renal failure, and you'll remember from the previous slide that in the presence of thrombocytopenia and anemia, the elevated lactate dehydrogenase level indicates hemolysis. His inflammatory markers were normal, and pretty much everything else, coagulation, screen, thrombophilia, vasculitic, and infectious workup was normal. And lo and behold, he is not diabetic. His urinary catecholamines were normal, and imaging of his urinary tract was also normal. He did go on to have a renal biopsy, however, and this showed thrombotic microangiopathy. This is a clinical entity that is well described, and it's thought to be related to endothelial cell damage and microthrombi, which causes mechanical damage to red blood cells as they enter the microvasculature, and this induces ischemic damage in end organs. The damage in his case was so severe that they weren't able to elucidate a specific cause for his microangiopathy, but they did do additional stains, and they were able to exclude ANCA-positive vasculitis as well as IgA nephropathy, so they've excluded that.
So, in summary, we have a 19-year-old previously well Asian male who presents with bilateral retinal ischemic microangiopathy, neovascularization, and dense vitreous hemorrhages. He's obviously got malignant hypertension with end-stage renal failure and thrombotic microangiopathy. And as Lee was alluding to, this really represents a diagnostic dilemma. Is the malignant hypertension a primary phenomena or a secondary phenomena in this case? Ming Lee, talk to us about the etiology of malignant hypertension as we understand it.
So you can see that there's an extensive list of causes of secondary hypertension. And this gentleman, remember, is 19 years old. So the first issue we had to face was, is his hypertension primary or is it secondary to something else? So the causes of secondary hypertension that also cause renal failure are listed on the left-hand side of the slide. And most of these have been excluded on the basis of serology as well as imaging. The one that has not been excluded is hemolytic uremic syndrome, which causes profound renal failure. It's thought to be a disorder of complement, where there is an acquired or sometimes a genetic disorder of the complement regulatory protein, such as complement factor H. And then the second issue in this gentleman was, what's the etiology of his renal disease? We know from his renal biopsy that he has a thrombotic microangiopathy, but there is, again, an extensive list of causes of thrombotic microangiopathy, most of which have been excluded apart from the two we mentioned previously, hemolytic uremic syndrome, as well as a secondary thrombotic microangiopathy secondary to malignant hypertension. But as ophthalmologists, we're mainly interested in the eye. So what's the etiology of his profound ischemic retinopathy? Is this thrombotic microangiopathy the same process in the kidney happening in the eye? Or is this just a very severe version of garden variety malignant hypertension?
So really, this is quite an unusual case of proliferative hypertensive retinopathy, of which there have only been 4 cases reported in the literature. Salman, obviously, in the context of this, the key is to lower blood pressure in these patients, but what do we do for the eye?
Well, interestingly, in his case, he is a barrier to his own care. I don't think he's compliant with his medication. That's why he gets repeated admissions with hypertension. So the first thing would be to try and control his blood pressure to make it safe. In terms of what you do, if this is proliferative hypertensive retinopathy, it's unique and there is very little evidence base except by analogy. So you would use anti-VEGF therapy and angio-guided peripheral retinal laser.
Which is exactly what he ended up having. So really, take-home message is this is a rare but important disease entity to recognise. And we obviously often don't measure blood pressure in our patients, but it's very important to do so. And I think that what we've learned through his repeated hospital admission is that we really value our strong links to St Vincent's Hospital and the medical care they provide with our patients. Case 2 is a 27-year-old female who presents with left-sided photopsias. She was seen by her optometrist who referred her to the emergency department to rule out a peripheral retinal tear. She had 6/6 vision bilaterally, a normal anterior segment and normal intraocular pressure. Xavier, if I could get you to comment on her posterior pole colour fundus photographs, please.
Yeah, they look pretty normal, which is probably not what you want to hear, but you show people those pictures and most people are going to say, well, you've shown me this, so there's got to be something wrong, so I'm going to make something up. So maybe there's something wrong with the left eye, but looking at those pictures, you're not going to pick up a whole lot. But what's interesting is we click on to the next slide, how much more obvious it is when you use the Optos. I don't know what it is about the optics or the particular lasers, but you get this quite incredible idea that something is really wrong here. I don't know if we've got the other eye, but that one was pretty normal. And it used to be you'd say, oh, well, you'd start thinking about MUDs, you've got the right demographic, and you'd probably do a fluorescein. I don't think I've done a fluorescein for a MUDs patient in 10 years. I would just put them straight on the autofluorescence. But you can see all these little white spots that are more confluent around the disc. And the autofluorescence is really now, I think, the diagnostic key. And you'll get this really particular pattern of disc-centric spread out in a centripetal manner. And it'll change over time and expand and then contract back towards the disc. And sometimes it'll leave you up with that AIBSC type pattern around the disc. But that pattern is almost diagnostic, except for one important exception that I'm sure we'll come to. That's more common in some states than others.
And could you comment on the OCT? What are we seeing? So normal right eye up the top, diseased left eye in the bottom. What are we seeing there?
Again, if you look at it just in passing, you might miss it. And we've certainly seen cases of patients who've had cataract surgery and things where they've had an abnormal outer retina, and because it's so subtle and you aren't looking for it, you aren't going to see it. And often it's only in comparison to the other eye that you will see that outer retinal sort of, I guess it's attenuation, moth-eaten, and just sort of spots missing there. And sometimes you'll see a little spike as well. And they correspond really well to an ICG of spots and dots, or dots on spots, where the dots are the little spikes and the spots are the larger areas of missing outer retina. So this is all shaping up really nicely to be MUDES.
So
I can say that because I know what it is, but I'm sorry to ruin your
He's
audience
ruined
poll.
my audience
But
poll,
if anyone
hasn't
gets
he,
this
really?
wrong after I've told them
I'd
that,
like to see 100% from
that'll
the
be a
audience at
red
this
flag
point.
and you'll be back into
If
registrar
not, you're going
training.
to sleep and talk to Xavier afterwards.
Yeah, sorry.
So we'll probably skip this one. So as Xavier alluded to,
Yeah, I mucked that up.
this is a case of MUDES. She was managed conservatively, slowly had improvement of her symptoms, and at 1 month, this is what we're seeing. Xavier, again, do you want to comment on her foveal changes that we're seeing on this slide?
Every now and again you'd see someone and they'd come in a couple of months later and say, it's just not quite right. And you'd see this sort of pattern at the macula, and that was thought to be pretty much pathognomonic for having had MUDES in the past. And it was really the only good sign sometimes you had that someone had definitely had MUDES. I don't know if I've seen this for a while because generally they've gone out into the community and we've discharged them. But the granular macular change is what we're looking at there.
Salman, did you want to say something about the foveal
If you
changes?
go back to that colour. So I want to draw your attention to the arterial health of this young patient. Have a look along the superior vascular arcade, look at the artery crossing the vein at 2 points. That is normal, but it is not healthy. It is widespread in the Australian population, and we see arteriolar sclerosis, and we almost always think that it's normal, but it's actually an unhealthy but common state. We can talk about arterial health in question and answers if you like, but it's interesting. It's sort of almost par for the course these days.
And on follow-up fundus autofluorescence, Xavier, sorry, I'm having
You're doing
slide flicking issues.
you're doing a
really.
good job. That's what you'd expect to see, and I do absolutely recommend you follow these people up.
And
Am I going to muck up the next present? I'm sure I'm going to muck something up if I tell you why I follow them up. I probably am.
you were going to behave, is that right?
Yeah, I'm trying to behave. The point being is that there's one really critical differential.
Yeah, don't mention that.
Yeah, and so I don't, but I don't know what it is.
Again, we're a great advertisement for Melbourne Retina. Yeah. So these are our OCTs, again, the normal right eye, and her follow-up imaging in the middle at baseline and then at 1 month later. And we can see a very nice resolution of those outer retinal changes that Xavier was describing. So really take-home messages for MUDES, healthy young females with a median age of 28 in a recent publication in Retina. They present with photopsias and acute loss of vision, and sometimes with an acute enlargement of their blind spot. They have these very pathognomonic, discrete white dots at the level of the RPE, and then subsequently go on to develop foveal granularity that we just showed you there. It's often unilateral, and as Xavier was mentioning, fundus autofluorescence has really changed the way we can diagnose these patients accurately. It has a very good prognosis and generally does not require treatment. Case 3 is a 38-year-old type 1 diabetic who has had disease since the age of 15. She has very poor control. HbA1c is 9.8 and she has early nephropathy. She had been seen for the first time in 2019 with 5 bilateral intravitreal injections done privately. And we all know what happens in 2020, and Melbourne becomes the most locked down city in the world, and she is lost to follow-up for more than a year. She presented to the Footscray Emergency Department, which is a hospital in the west of Melbourne, in 2021, with sudden, in inverted commas, loss of vision in her left eye. At that stage, vision was 6/9 in the right and hand movements in the left. She had normal anterior segments, and they took one look at her and referred her promptly to the emergency department at the Eye and Ear. Salman, what can we see here in the right eye?
So there is intraretinal lipid, retinal arteriolar narrowing, intraretinal hemorrhages, microaneurysms, consistent with a retinopathy.
Left eye?
Badness.
Yeah, slightly more retinopathy. So this is a tractional retinal detachment. There is an area inferotemporally fibrovascular tissue, but a widespread, perhaps combined tractional and rhegmatogenous retinal detachment.
And the run of the angiogram on the right.
So multiple areas of retinal neovascularization, patchy or confluent capillary closure, especially temporally.
And the left.
And in the left, widespread leak. Really, an angiogram in that doesn't assist you as much. You just see widespread leak, areas of neovascularization.
OCT in her right eye at baseline.
So surprisingly good. The retinal layers are relatively well preserved. Outer retina is well preserved, the photoreceptor layer, interdigitation zone, etc. So not bad. And her visual acuity was good in this eye. So that sort of fits together. The retina, the macula has multiple redundancies in terms of nutrition and glucose. So it's a very late indicator of severe disease. And in the left eye, obviously, a retinal detachment.
So in summary, we have a young woman with bilateral proliferative diabetic retinopathy secondary to poorly controlled disease. She has a left traction detachment and she has had no treatment for more than a year since being lost to follow-up. Now time for an audience poll. If you had seen her originally in 2019, assuming no diabetic macular edema, how would you have managed this patient? Would this have been a patient that you would have done anti-VEGF alone? Would you have done PRP alone, or would you have done a combination? Could we go to the next poll, please? So we've got sort of a 1/3, 2/3 split between PRP alone with 1/3 and a combination of anti-VEGF and PRP. So we saw her in 2021, and at that stage her left eye was referred to VR. As you can imagine, she underwent a vitrectomy, delamination, endolaser and gas, and the right eye had pan-retinal photocoagulation alone. When I saw her last month, she had visual acuity of 6.6 in the right and 6 on 9.5 in the left, thanks to our amazing VR unit. Her right eye had not changed throughout the time that she'd had pan-retinal photocoagulation in terms of her OCT appearance, and the left had an amazing restoration of its foveal and macular contour. So what do we know about these patients that get lost to follow-up? This is a great study that I always think about. It came out from Wills Eye Hospital just over a year ago, looking at this exact phenomena. Patients with PDR that were lost to follow-up over a 4-year period were tracked. These patients could have received either intravitreal anti-VEGF therapy or PRP to treat their disease, and they wanted to compare clinical outcomes. And this paper defined lost to follow-up as 6 months or greater between their last appointments, and they found 76 eyes from 59 patients who met this criteria. 30 of whom who had received, I don't know why this slide is not working, 30 eyes who had received anti-VEGF alone and 46 who had received PRP. And the outcomes were that those eyes that had received anti-VEGF therapy alone did far worse in terms of rates of blinding diabetic conditions, so higher rate of tractional retinal detachment and neovascular glaucoma, and they had worse visual acuity had they been treated with intravitreal anti-VEGF alone and then lost to follow-up. And they concluded that given the potential for sequelae of being lost to follow-up, the choice of treatment for proliferative diabetic retinopathy must be considered carefully. And so really for take-home message number 3 is that eyes with PDR and no DME at baseline, PRP should really still be considered the top line for management. Case 4 was a 75-year-old female who presented to the optometrist 10 years ago with difficulty in reading. She was noted to have bilateral macular changes and referred in to her ophthalmologist with AMD for management. Robin, our world expert, can you comment on her colour fundus photographs at baseline?
Thanks, Amy. So we can see here clearly that the left eye's had cataract surgery and the right has not. She was 75 years old. She's been referred in for AMD. A very reasonable diagnosis. You can see on the colour photo that there are in the macular deposits. They resemble drusen, so completely reasonable to think this lady has AMD. There is actually in the left eye perhaps an area of atrophy, and you can see choroidal vessels in the base. So I think the only thing that I might comment, particularly in the right eye, is perhaps the lesions are a little linear. as opposed to round for drusen, and perhaps slightly different disposition in that they're slightly more temporal. They're not actually centred on the fovea, but a reasonable thought.
And her OCT?
So again, reasonable to consider this as AMD. You can see the beginnings of atrophy. You see the hypertransmission into the choroid. You can see loss of the RPE, and you see the subsidence of the outer plexiform internuclear layer, particularly on the left there. And so, again, quite a reasonable diagnosis. And perhaps the only thing I would perhaps comment on is, whilst there may be a typical looking drusen there on the temporal side of that left eye, there are the drusen, if they are drusen, are slightly funny in shape, particularly in that right eye.
So we'll do another audience poll. What is the diagnosis here? Is this something weird and wonderful like PXC with angioid streaks? Do we have an inherited retinal disease such as Stargardt's or another form? Sorry. Is this AMD, as the optometrist suspected? And while we're waiting, could we get the other poll up, please? What extra tests, Robin, in this circumstance do you find indispensable?
Yeah, so thanks for the poll, which shows that it is very difficult to make a diagnosis. So we've got a bit of a scattering of what people think this is. And so the autofluorescence image that was flashed up is, again, the reason to present this is to show how valuable autofluorescence is, if I could go back to the autofluorescence. At the moment, when we're just about to embark on treatments for geographic atrophy secondary to AMD, and atrophy as a result of inherited retinal diseases, is very important for us to try to make the difference. And this is really a plug to use autofluorescence. This is, when I see this, it's clearly not AMD. The background autofluorescence is odd. It's this sort of amorphous, highly reflective grey sort of appearance, and then those things are now called, I would say, a flex. They're not drusen. They're very hyper autofluorescent, and so very untypical of someone or atypical of someone with AMD. So I would, on the basis of this, be quite confident that it's much more an inherited disease and looks very much like Stargardt's disease.
And a follow-up 10 years later, Robin, is the OCT giving us any more information than it did at baseline?
So again, it's really just showing that it is atrophy. If you just looked at the OCT, you would not really be able to tell the difference between atrophy secondary to an inherited disease and atrophy secondary to AMD. And if you show the autofluorescence, Amy, this could easily get into a geographic atrophy study. It's got, perifoveal atrophy. It's got the foveal sparing. We know that happens in AMD. I'm sure cases like this get into GA studies, and it's really that autofluorescence that, again, helps.
So take-home messages for this case is that, obviously, as Robin was alluding to, we're entering an era of novel treatments, not only for inherited retinal diseases, but also for geographic atrophy. So it's really beholden to us to differentiate. Genotyping hopefully will become more widespread and will help us with this, but fundus autofluorescence really is becoming mainstay of all of our macular degeneration and IRD patients, and hopefully we can embrace this. Case 5 is a 14-year-old boy who went to his optometrist just because his mum wanted him to have his eye checked, and he was referred in that night to emergency for an urgent review. He'd had no eye symptoms, no blurred vision. He had no past medical history and no family history. He had visual acuity of 6/5 bilaterally. And we'll start with the left eye, Salman. What do you see? Sorry.
We've got a hair trigger on that mouse. So the left eye's completely normal. So, it's interesting. This is just like the angio meeting, because when I had it in Melbourne, I had a mouse with a hair trigger that just had a mind of its own.
It's not quite, though, because you would normally harass the registrars about the Venus caliber.
And then you tell us all not to eat.
Yeah.
It's all coming out now.
Okay. So
We will go back to the left eye if this slide will stay still. No, it's not going to stay still.
Look, those of you who don't feel like you're participating in the meeting, we are selling merchandise from the angio meeting, the annual tiers of the registrars. Every year there's a different vintage. So the left eye is completely normal. The right eye has what appears to be a vascular lesion in the infranasal periphery.
And the angiogram?
And the angiogram shows a retinal vascular lesion with multiple areas of saccular dilation. Although the contrast doesn't show the remainder of the retinal vascular tree, it does show, I can tell you that it's only restricted to that area and there is no coarsening of the capillary bed elsewhere.
And his normal other eye. So what is the diagnosis? So we didn't do an audience poll for this one only because it's one of those spot the diagnoses in ophthalmology. And this is a retinal cavernous hemangioma. What is it? Well, it's a rare vascular hamartoma in otherwise normally fit and well people. As someone was saying, it has a thin walled-like aneurysms giving us this classic grape-like appearance, which is how it's described in GAS. It's unilateral and remains asymptomatic and is usually detected under exactly the circumstances as this one was. It can cause macular traction and vitreous hemorrhage, but this is rare. Generally, when you follow up these patients, they don't change over time. And in fact, the only reason why this young boy hasn't been discharged from the medical retina unit is so that registrars can see him on an annual basis.
Yeah. The other point just to make with that is that, especially in Victoria, we've had to examine patients with masks for 2 years. And I'm not sure about you, but for me, it's really impaired my ability to look at the peripheral fundus. And I worry how much I've actually missed. It's very hard to examine a retinal patient with a mask on properly. I now get them to put their mask down underneath their chin and examine them in the usual manner.
Back to retinal cavernous hemangiomas. So the take-home message is very, very rarely. It has been described that they can exist with cutaneous and CNS. Cavernous hemangiomas, certainly in GAS, it's been described that dominant pedigrees do exist. And so occasionally neuroimaging is warranted in these patients. Case 6 is a 35-year-old female who went to see her optometrist who really did not know what was going on and referred her in with either Stargardt's or an autoimmune disorder. She'd had 3 months of bilateral photopsias, especially in bright lights, and 6 days of essential left-sided blur. She was a low myope who was otherwise fit and well. She was married with no extramarital sexual contact, but had 3 months of non-healing roof-of-mouth ulcers, inflamed glands, and generally feeling unwell. At presentation, her visual acuity in the right eye was 6/6, but her left was 6 on 120. She had white eyes with normal intraocular pressure and just a trace amount of AC activity in both. There was no vitreous haze in the right eye, but in the eye with poor vision, she had quite a decent amount of vitreous haze. Xavier, anything to comment on the right eye colour picture?
No. I can't remember the exact order of cases, to be perfectly honest, because this is quite real life. So, no.
At the left?
I think I asked Ming Lee, do you remember what this one was?
I'm going to get
no,
to the colour
I do.
photos.
I'm on board now. I'm on board now. Yeah.
He went to a wedding last night. Okay, so.
It was a few nights ago.
And still recovering.
Out of practice. Look at it, from what I recall, it looked kind of normal, just looking at the colours that look pretty normal. And, you can be really think that the person who saw the patient before has really missed a great deal when you show them the Optos pictures. This one doesn't show it quite as well as the last one, and there really isn't a great deal to see. You maybe got some artefact out in the edge, or maybe that's real, you don't often know. Maybe there's a trace amount of disc swelling, but look, there's nothing really that impressive there. Whereas when you get the green light autofluorescence, you're going to pick something that's pretty wrong there every day of the week. And you've sort of got a similar sort of picture to what we saw before, although it's bilateral and you've got some more confluent changes around the posterior pole. So, you're heading in the same sort of direction we were before, but there's some differences.
And her OCT at baseline, right and left?
And, if you flash those pictures up compared to the one we saw earlier, I don't know if you could pick a difference. The top one looks okay on the right side, but the left one looks really similar to what we saw earlier.
Well, that's a good segue into another audience poll. So Do we have another case of MUDES? Is this syphilis? Is it azor? Have we got a masquerader, something like lymphoma? Could we get that audience poll up, please? But I agree with Xavier, you know, they're almost indistinguishable, except the fundus autofluorescence suggests that this is a bilateral process this time, but their baseline OCTs are certainly very similar. So we've got at least half of you thinking that this is syphilis. I don't know that that's because we're from Victoria, but you are right. She was syphilis serology positive.
Well, I think that if it was Sydney, you probably wouldn't have a differential.
There would be no poll. So these are her images 3 weeks after her penicillin. And you can see, Xavier, what are we seeing here in terms of restoration of her?
It can be, you know, and I think Robin, have talked about this when we've seen patients who've lost outer retina. Because I remember you being horrified. We had a patient from Malvern who had this pattern, and that's where Robin lives. And they can really reconstitute quite amazingly well, and you think that the eye is absolutely shot, and it remarkably comes back. And all they've really had is the penicillin. And the other thing to say about these patients is, you know, you're going to see them at maybe week 3, week 4, and then they disappear. You don't see them ever again, or you might see them in a couple of years, but it's quite remarkable how much they recover and how quickly generally. And the two predictors of them recovering is how long have they had it and how bad is their vision at the start. But this one had pretty bad vision at the start.
Just because we can't get enough, this is a 54-year-old male who's an executive in a multinational company, travels a lot for work, and he was referred to the eye with unexplained vision loss in his right eye. He'd had what he described as an upper respiratory tract infection 4 months ago and was generally feeling unwell. He was fatigued, he had shoulder pains. His GP had done a preliminary workup and referred him to a rheumatologist with an ESR of 90, and a diagnosis of polymyalgia rheumatica and rheumatoid arthritis was made. And this patient was commenced on oral prednisolone and methotrexate simultaneously. Xavier, again, are we still looking at a fairly unremarkable...
Yeah, pretty much.
His visual acuity at presentation was 6 on 90 in the right and 6.6 in the left.
Now, that doesn't knock out MUDES out of the equation. If there's a good paper in Retina, I think 2017, 2015, talking about the extended clinical spectrum, and one of theirs had sort of 720 vision. So you can get really bad MUDES, but it's not quite that common to be that bad.
And again, similar findings on autofluorescence and OCT?
Yeah, I think so. You know, so the question is really, who do you test? And normally what we do is we go through a little pattern in our head. We go, what's the pre-test probability? But as someone told me earlier, a couple of weeks ago, it's very hard to get pre-test probability in this because people don't tell you the truth. You know, we had the guy who was a virgin, and he was, you know, had the immaculate infection, and they just aren't going to tell you what the story is. And then, you know, Ming Li thinks that, you know, men are the source of all evil. But, you know, the case from the previous one said that, you know, it does happen in females too. It's probably some man somewhere along the track. But
I think it's 9 to 1, but
yeah,
anyway.
well, and you know, we had the 87-year-old who did a trip to New Zealand and came back with it, and we thought he had some sort of neoplasia, but no. And then we told him, oh, you've got syphilis. Oh, yes, that's because I did this. And you're like, oh, well, gee, that would have been handy. So the question is, who do you test? And my theory is you have an atypical patient, an atypical response. So if the patient is not a young female, then you think, okay, it's got to go up in your list. If the pattern is atypical, so yeah, bilateral is a big risk thing. If you're getting those confluent areas, that's a big risk thing. And the reason for following up the MUDES cases is that if you don't test everybody, the syphilis ones aren't going to get better. So if they start getting worse, you really want to be testing for syphilis at that time. And then you put all that in, and that's where I sort of draw the line on what I test. I don't test everybody because you do get false positives, and you know, Ming Li, we had that 14-year-old girl, and that caused a lot of problems because now you've got a syphilis positive test in someone who, you know, it's a potential risk of child abuse, and what are you going to do with it? And we went down a lot of avenues to try and sort that out. So I don't test everybody, but atypical patient, atypical presentation, and atypical response are the ones I test.
So obviously we know that this patient had positive syphilis serology, as Xavier was saying, and again had a really good response to IV penicillin. So near on complete recovery of his vision and reconstitution of that outer retinal zone there. and then here's his other eye. So take-home messages for these two cases of placoid syphilis is always think it, but you might not always test it. For it, as Xavier said, it's a great mimicker. Fundus autofluorescence, again, is really useful for both diagnosis and follow-up. And often the visual acuity is much worse than you would expect. We really do need to be taking excellent patient history on all of our patients who present like this. And the reason is between the 5-year time period between 2015 and 2020, we all know that there's been an explosion of syphilis. Notifications have increased by 350%, and in the same time period, chlamydia has only increased by 23% and gonorrhea 123%. I don't know whether to take heart from that or not.
Part of that's because of the availability of, not to go on a tangent here, but pre-exposure prophylaxis is very available. And on my drive to the eye, and here I go past a, well, I don't know. And it's got a big sign out the front saying, PrEP available here, no need to wear protection. But of course, you know, this is one of the reasons why this has come up and become such a prevalent thing. And, you know, if I recall the Bevidex trial, you know, one patient did really badly in that one because they had steroid in the eye of syphilis. So it's becoming so prevalent now. I would say we'd see 1-2 cases a week. Would would that be fair?
Oh, that's probably an overestimation, but yeah, it's very, very prevalent, and it doesn't choose. You know, it's in Malvern, it's in Williamstown, it's everywhere.
Except the lady from Malvern just moved to Malvern.
I thought you'd been there a while.
I think it was a man.
And I live in East Malvern.
The right side of the tracks.
Amy, didn't you have a case where syphilis reached out from the grave?
That was not my case, no. I had syphilis that reached out from Armidale.
No, the patient whose husband had passed away.
Yes, that is her, correct. Yeah, she was the lucky beneficiary of many things in his will, including syphilis. I don't have her images, however. This case is an 80-year-old female who was referred to the INEA by a country Victorian private ophthalmologist who she'd had acute on chronic visual loss over 6 to 8 weeks prior to her referral. She was known to have advanced primary open-angle glaucoma treated with drops, and when she went to see her ophthalmologist, he noted her to these widespread lesions on OCT, which I will come to in a minute. She denied photopsias, floaters or systemic symptoms. However, this woman is not well. She's got an extensive past history. She's in end-stage renal failure from a congenital single kidney, is on peritoneal dialysis, is hypertensive, has dilated cardiomyopathy. She has peptic ulcer disease, heart failure, multiple forearm squamous cell carcinoma excisions, and a meningioma that had been resected twice, once in 1995 and another time in 2005. She was on multiple medications and was really not in great health, living at home on a walker, very frail, with limited exercise mobility. So with that as background, at presentation, vision in the right was 6/9 and left was 6/24. She had normal anterior segments in essence. At Man's Best Eye Hospital, the Royal Victorian Eye Hospital, we still have handwritten notes, if you can believe it. And this is the very first time she was seen. And one of our very astute medical retina consultants noted her to have these bilateral yellowish lesions at both her foveas, as well as a 3-disc diameter elevated lesion in the superior aspect of her left eye. Bingley, are we seeing these lesions that the clinician saw on colour fundus photograph?
So you can see from the pictures that those faint yellow lesions are really quite difficult to see, but perhaps with the eye of faith in the right eye, you can see just superior to the fovea, a yellowish pale lesion. There's a few of them and they're quite small. In the left eye, very, very difficult to see, but they're sort of infero-nasal to the fovea. There's a few of them again. But notice that there's not a lot of inflammation. The view is really clear.
Does this help?
Not really. So there are some areas of altered autofluorescence corresponding to the lesions seen clinically, but again, it's not very brightly hyper autofluorescent. Perhaps in the center of the lesions on the right side, the very center has an increased autofluorescence pattern. Similarly, in the left eye, there's a slight increase in the autofluorescence in the lesions just at the fovea and also infranasal to the fovea.
And we did notice that sort of unusual appearance of the disc that we referred to glaucoma, and they just said it was glaucoma.
Not a glaucoma symposium. So moving on to the peripheral lesion.
Peripheral
So
lesion
you
that was
can see
noted.
that the elevated amelanotic lesion that was described in the clinical notes is obvious in the superior aspect of the left periphery. It is only slightly elevated, not a lot of obvious subretinal fluid or hemorrhage surrounding it. And the autofluorescence pattern does not delineate the lesion at all.
Salman, I might ask you to comment on her bilateral OCTs at baseline. What are we seeing here?
So she has multiple lesions at the level of the photoreceptor and pigment epithelium in both eyes. These lesions can be described as vitelliform, although it may not be completely accurate, but let's just go with multiple vitelliform macular lesions.
And the infrared imaging?
So again, you can see the areas, the circular areas in the left eye corresponding to these multiple vitelliform lesions of differing size, and some in the right eye as well, although there is a sort of more geographic pattern.
Is the angiography contributing much
So
here?
the angiogram late shows some diffuse late hyperfluorescence of the peripheral slightly elevated pale lesion.
So we'll do another audience poll, if we could get that next one up, please. So what's the diagnosis here? This is quite an unusual constellation of findings. Is this lymphoma? Is she on a MEK inhibitor that we didn't know about? Is this a paraneoplastic phenomena, or are these metastases? What do we think is going on? So at least half of you think that this is a paraneoplastic phenomena. Well, with that in mind, a strong showing from lymphoma as well. So we might go back to the talk. Thank you. So we got some corroboration from her GP and the rest of her family. She wasn't in great health. And really, we wanted to focus on the risk of malignancy in this patient. In 2019, she had a CT and a PET done because, and was found to have what was thought to be a low-grade adenocarcinoma. The patient did not want this investigated, and so biopsy was deferred, and she did not want any treatment for this. She'd had multiple squamous cell carcinomas from her skin excised, but no known melanomas. So our working diagnosis was a paraneoplastic phenomena. Ming Li, what do we know about paraneoplastic phenomena in the eye and how it works?
So we think that paraneoplastic syndromes are signs and symptoms that relate to indirect effects of the tumor, either from the tumor producing hormone or growth factor that acts in a distant site from where the original tumor is, or from an abnormal host response to the tumor antigens. So said in a different way, this is the host generally secreting autoantibodies towards the tumor that cross-react to retinal antigens. And there's a number of paraneoplastic syndromes that most of you are familiar with, most common being carcinoma-associated retinopathy and melanoma-associated retinopathy. In CAR, the diagnosis of a tumor is may not be made when the patient comes with the retinopathy. However, in melanoma-associated retinopathy, the patients generally already come with a known diagnosis of melanoma. And then there are others that are quite rare, such as diffuse uveal melanocytic proliferation and paraneoplastic optic neuropathy. In our particular patient, we thought due to the multifocal serous retinal detachments and the vitelliform-looking lesions in both eyes, we thought that this was consistent with a polymorphous paraneoplastic vitelliform maculopathy, which is a very rare entity. It's thought to be autoimmune, and that appearance in the retina is certainly not specific to paraneoplastic phenomena, can occur in many other different conditions, but in the right clinical setting, should alert the clinician to a paraneoplastic disease.
Xavier, do you have any more comments on this entity or anything to highlight?
Well, not really is the answer to that because, gosh, I'm going to pretend I know a lot about this, but which is the name of the game here. But I had to go and look a lot of this up. Gass saw his first one in '87, and then another one the same year, and didn't see his next one until 11 years later. So if he's seen 3 over 10 years, the chances that I'm going to see another one are small. Nonetheless, I'm going to pretend I know a lot about it now. From what I've read, when I saw this patient with the doctor's handwriting was there, we all sort of gathered around and thought, oh, look, this patient must be on a MEK inhibitor. It's the only thing I've seen do that multifocal sort of CSR-like pattern without the gravitational pattern. So there must be. They're on a whole bunch of drugs. They've probably just forgotten one. And then there was the lump. Well, what's going on there? So that was all pretty weird. But having gone back and then read about it, most of these have been described in association with melanoma, be it cutaneous or uveal. But since then, it's sort of been implicated in other sort of carcinomas. But the real one I have with this is I got shown a case of this maybe 2 years ago by one of the other consultants who said, I think this is AEPPVM. But the differential is the critical thing because autosomal recessive bestrophinopathy can look pretty similar and it can be really hard to split apart. And this one's a little bit more obvious because she's got a carcinoma and she's got a lump in her eye. And so you're a bit more obvious. But how do you tease these two apart? Because they can be quite significant differences. In one case, nothing you do is going to change anything. On the other hand, the patient's got a sort of life-threatening carcinoma. And all I could come up with really is these ones are more likely to have symptoms. The autosomal recessive bestrophinopathies often are just incidentally detected because they may not have a macular lesion. If you do the OCT macular thickness, you'll find the ARBs often have a thin central macula if they don't have cystoid. These can have cystoid or can have normal retinal thickness. So really it's about the differential. And if you can't really be conclusive about one and the other, then you've got to go looking for a cancer. Even if you've got a prodromal virus history, I think you've still got to go looking.
Which is really exactly what we did. So in our mind, probably the maculopathy was just really the tip of the iceberg in this patient. She went on to have a number of investigations. She was known to have renal failure and was on peritoneal dialysis, but essentially full blood count and LFTs were normal. She had CT chest, abdo and pelvis with comparison to her scans from 2019. She'd had a couple of those lesions in her lung already noted, 2 of which had increased in size, and there was a new lesion as well. And the other parts of the examination, apart from her emphysema, were relatively normal. She had a PET scan as well, which showed these lung nodules were minimally active with no nodal or metastatic disease. She had a normal MRI brain and orbits, normal mammogram, and normal colonoscopy and gastroscopy. So for a woman who really didn't want to be investigated, she really was. And we had a multiple disciplinary team meeting with cardiothoracic surgery, medical oncology and radiology. And really the take home from that was that this is a probable or possible low-grade lung adenocarcinoma. She was still not keen on a biopsy at this stage, nor any treatment for it. So really the recommendation was just to do serial CT chests. So back to our original presentation and pictures. Salman, we don't have a clear primary. We could have a primary lung adenocarcinoma, or as Xavier was alluding to before, some of these cases have been described with uveal melanomas. Is this our primary, the top lesion? Or?
Yeah, so it's interesting. I think that is a metastasis from looking at it. It looked like a metastasis. It would have that sort of appearance, pallor with some pigment change, elevation. Generally, this condition in the literature has been reported with increased disease burden, so it mimics severe systemic cancer burden, which is clearly the case in this patient. So I'd say that this is a metastasis. Interestingly, whilst the predominance of the evidence is that this is an autoimmune condition, and that sort of fits with the appearance that we can see, in the one histopathological specimen, they've actually found spindle cells in the vitelliform lesions resembling the primary lesion. So it's yet to be resolved, but given its appearance that it's similar to MEK inhibitors, I do think it's probably likely to be autoimmune in origin. Again, this was another case where examining the patient with the mask on made it almost impossible to see that lesion. And that's the sort of nightmare over 2 years, is that you miss something indolent like this in patients. You had to take the mask off and she was immunocompromised. The one other point, although it's not entirely clear from the history, I was left with the impression that the doctor who had ordered the initial CT scan had his practice had filed it without him having a look at it. And so I just make that point that whenever you order something like a CT scan or bloods, especially as an ophthalmologist, always task yourself in your EMR software to look at, don't ever assume that someone else will take that for you. Always look at it yourself. Always remind yourself that you need to follow up any investigations that you make.
So take-home message, this is a rare paraneoplastic phenomenon, presumed to be, which we need to really recognise, if only to realise that it's just the tip of the iceberg. And we need to have good ties, again, with some colleagues who can help us investigate these patients further. It's most commonly associated with cutaneous melanoma and choroidal melanoma, but has been more recently described with lung adenocarcinoma. So a 78-year-old female who presented to her optometrist with difficulty reading, particularly in low light. And this optometrist was hot on the fact that at CIRA we were running trials for intermediate AMD and referred her in for participation in one of these. Robin, what are we seeing on her photo colours here?
Thanks, Amy. So again, optometrist has said this person is intermediate AMD, and looking at the colour photo, that's a reasonable thought. You can probably see drusen there, yellow sort of creamy deposits at the macula. They're round. Yeah, why wouldn't you think that that was intermediate AMD? And I guess the only other thing that I can possibly see that is easily missed is perhaps in the just outside where you can see the drusen. There's sort of a mottled appearance slightly further out that aren't quite typical of drusen. Yeah.
On infrared?
So the infrared, looking at that, there's an awful lot of little darker deposits. Some of them, if you look carefully, have like a little central donut. The thing that I would remark upon is that they're quite evenly spaced and they're all similar size. So possibly you will be thinking that there's an awful lot of regular sized drusen evenly distributed in both eyes.
And her autofluorescence?
Similarly, I think here you could be thinking that, again, this mirrors the infrared in that there are multiple hypofluorescent spots. Perhaps they could be due to drusen. Just ignore that hypofluorescent thing, that's something different. But again, there's this even distribution that I would be thinking that's slightly odd for drusen to be so beautifully distributed and so far out into sort of the under the arcade area.
So we'll go to our next audience poll. We've done our multimodal imaging. What are we seeing here? Is this reticular pseudodrusen? Are these basal laminar drusen or cuticular drusen? Is this a case of familial dominant drusen, or are these just sort of conventional drusen that we see with AMD? If we could go to that poll, that would be great. So 2/3 of you are saying reticular pseudodrusen. Robin, before we move on to the rest, what's the most useful form of imaging that you use for your macular degeneration patients?
Yes.
Do you use a combination, or is one the key?
So when I see someone for the first time, I do everything. Colours fundus photo, fundus autofluorescence, IR and OCT. And I think we'll see in the next slide that really the answer to this question comes from looking at the OCT. So those who said that was reticular pseudodrusen are correct. And reticular pseudodrusen different from conventional drusen in their location. And hopefully you can see here that the RPD is above the RPE. Maybe, Amy, you could point out where the RPE is. So you can see quite clearly that it sits on the RPE, whereas conventional drusen are always underneath the RPE. And that's why you really need the OCT to differentiate. And whilst I showed you a beautiful case where it's quite obvious once you see it that they are reticular pseudodrusen, often it is not as obvious as that. And so really the OCT is required for you to be sure that they are on top of the RPE.
So as Robin said, these are reticular pseudodrusen. Before we go on to why that's important, I'll just present another case. This is a young man, 44, who went to his optometrist with good vision of 6/6, no family or past ophthalmic history, and was referred to with AMD at the age of 44 to an ophthalmologist. Robin, again, I'll get you to comment on his colours.
Yeah, so as a cursory look, you might think this is the same as the one we've just seen, but a lot more of evenly spaced, sort of regularly sized drusen that go out way beyond the sort of arcades. both eyes, and the thing that Amy points out is they're 44. So we do know that you can have early onset drusen, so you wouldn't really call this AMD because they're not that magic age of 50, which, by the way, is not that old. Yes, so I see a whole lot of small drusen.
And the OCT?
Yeah, so similar to the last case, you might just think that this is another case of reticular pseudodrusen. They're all evenly spaced. They're all roughly the same size. And you can see these small deposits. But if you look carefully and were listening to what I just said, perhaps you might note that they actually sit on Brooks membrane and in fact are underneath the RPE.
So we'll do another poll if we could get that up. So Robin's giving you one answer that it's not. I've got the same 4 different drusen types. She's just told you it's not reticular pseudodrusen. So what are these? So we've got a lot of people who think this is dominant drusen pedigree. He had no family history, however. So we'll go back to the talk.
I think the thought of mulatto levantinacea is reasonable, but in fact the pattern of the same size drusen is radial, and so you see this beautiful radial pattern which this case did not have, and also a lot of drusen nasal to the nerve head. But it's a reasonable thought because in fact the drusen in mulatto levantinacea are what's called basal laminar deposits, and in fact the correct answer here is cuticular drusen, and they are often evenly spaced, and you often call it as a sawtooth pattern because they're tiny little deposits on Brooks membrane.
Before we wrap up the drusen bit, we'll just do one more case. So, Robin, another case again. No history here, but colour fundus photographs.
Yeah, so let's assume this is a 70-year-old lady, and here this looks very typical of AMD. I'm sure we all agree that there are drusen that look like drusen. There's some pigment clumping. You would assume this person has intermediate AMD, and there's perhaps a patch in the right eye that you might be thinking is a little patch of atrophy. So I put this one in as like a typical presentation of just intermediate AMD. Here you can see the drusen are actually that sort of paler white, whereas in those earlier reticular pseudodrusen it was much darker. And you can see we don't have that beautiful whole of eye pattern in those other 2 diseases. But the point here is it's often hard to tell unless you get those beautiful classic cases. You can get people with typical drusen that actually also have cuticular drusen and reticular pseudodrusen. So you can have 3 different drusen, if not more, in the one eye. And so the point here really is to show it's a bit hard to tell. Perhaps some of those lesions are reticular and some of them actually have a base on Brooks membrane, so they would be cuticular in the one eye. Moving on.
Yep. It's gone from wanting to move all the time to not wanting to move. There we go.
Yeah, and so I've tried to point out here, the cuticular drusen tend to have that little hyper transmission signal because the RPE is thinner on the top, and so you get this what's called bar coding, and that's very typical of cuticular drusen. But often difficult to tell the difference. I'm not pretending that it's easy, particularly in an eye with these mixed phenotypes. And so one of the clues was perhaps the cuticular drusen patient was 44, so that's not likely to be regular drusen. RPD is often in an older person, but you can have, as I said, the same in the one eye. And then just moving on to why on earth does it matter? And perhaps this OCT was just a blow up just to show you my point in that the RPD is above the retinal pigment epithelium, whereas the cuticular drusen are below the RPE, but sometimes hard to tell. And sometimes you like to use the wavy EZ line as a help for reticular pseudodrusen, stage 2 reticular pseudodrusen, say that you get this sort of wavy line, but here's a beautiful demonstration where either can cause that, so that's not much help. Why does it matter? Well, just the lead study was a study looking to see if we could slow the progression of intermediate AMD with a nanosecond laser, and the results were no. As a group, we made no difference. But when we separated those into those with and without RPD, hopefully you can see there, if you didn't have RPD in the laser study, the laser study really slowed down progression compared to sham, which is the top graph. Whereas in the bottom graph, if you did have RPD, perhaps laser was not a good idea. And so the point being that it will become important to differentiate these different sorts of drusen because probably they have different mechanisms of cause and probably the treatment's going to be different. So as we inch towards treatment, we're going to have to be able to differentiate who's got what because at the end of the day, they'll probably need different treatments.
Thanks, Robin. So cases 12 and 13 will be presented side by side. So the first is case 12, a 32-year-old gentleman who presented to the Ione Hospital Emergency Department in May of this year. And he'd had 2 weeks prior to his presentation of just general malaise, muscle aches, fevers and headache. He'd been seen by his GP, who'd noted him to have raised inflammatory markers and referred him to the Austin Hospital in Melbourne. He'd had a full set of bloods done and a liver ultrasound, which showed really nothing. Prior to his presentation to the Ione, however, he'd had 2 days of progressive bilateral visual loss. He was a mild myope, and really on systems review, he'd had some headaches in the last few days, had some tattoos done recently, but these were not infected or inflamed. Visual acuity at presentation was 660 in the right and 618 in the left. He had injected eyes with 3+ of anterior chamber cells, some trace vitreous cells in the right eye, normal discs and bilateral pale placoid lesions in both retinas with some cystoid macular edema in the right eye. Xavier, can you comment on his colour pictures?
Yeah, it's actually a lot clearer when I look back there, so I apologise if I've missed a whole lot of signs before. First thing to say about the systems history, having spent a week in the Gold Coast, is having tattoos is not a significant finding. It's not having tattoos that is more common. This pattern can look like a few things. You've got these large sort of posterior pole lesions that are yellowish, and we're thinking inflammatory, but you've got to exclude infectious and neoplastic as well. But yeah, something definitely going on here. This was a little bit surprising. I sort of had a diagnosis in mind, and is there a poll on this one? There is, yep. So I had a diagnosis in mind, and one of those pictures really didn't fit with what I had in mind or what I thought you were supposed to see. So, one side's got cystoid macular edema and a bacillary layer detachment. Another's sort of got this more sort of small little areas of detachment, sort of, I guess, fuzz of the outer retina is probably the most eloquent way I can describe that. But it wasn't quite classic at this stage. So we actually decided to get an angiogram. We don't always do angiograms on these ones. But there were some other things in the anterior segment. The patient had a lot of cells, if I remember correctly, which was also unusual. But we went on to do the angiogram to try and look for these pretty classic findings. And I think we got them. And so we sort of thought, oh, well, we've got a diagnosis here. It's very likely.
Before we go to that diagnosis, I'll present case 13 in tandem. So he's a 31-year-old male who presented to an emergency department in rural Victoria this time and had a 3-week history of fever and neck stiffness. He was admitted at that point, had a CT brain and lumbar puncture, and really no cause once again was found for his presentation. After discharge, he had 11 days of progressive loss of vision bilaterally and was referred at that point to the Ione Hospital. He'd had a retinal detachment 15 years prior at the age of 15. And again, really his systems review was negative. Visual acuity was poor, 660 in the right and 690 in the left. He had quite a lot of AC cells, some trace vitreous cells in both eyes, a normal disc, and again, these pale placoid lesions that we saw in the other eye, in the other case. Ming Lee, do you want to comment on these colours?
Thanks, Amy. So you can see very similar changes again, bilateral placoid lesions affecting both maculae. Notice how there isn't a lot of vitreous inflammation in either eye, and the discs don't appear very swollen. And also, the lesion in the right macula seems to be of different ages. So you can see the bit down the bottom looks a little bit fresher than the bit up the top, with a bit more pigment clumping up the top. In the OCT, again, there's loss of the ellipsoid layer in both eyes, more profoundly in the left eye, associated with thickening and hyperreflectivity of the RPE in the left eye.
So we'll go to a poll, if we could get that up, please. So what are we dealing with here? We've got 2 young men who present with bilateral visual loss. Is this a masquerade syndrome like TB or lymphoma? Are we dealing with AMPI, or are we just syphilis on the brain at the moment? We'll get those polls up in a minute. We've deliberately done it before. We've shown you some other investigations. So overwhelmingly, everyone thinks that this is AMPI. Patient 1 and patient 2 obviously both had negative syphilis serology, and really their findings were had some raised inflammatory markers, and patient 2 had an abnormal FBE, but they both went on to have normal brain MRIs excluding cerebral vasculitis. So most of you are quite right. Xavier, do you want to talk to us about?
Yeah, so I think some of those differentials are really important. And I remember seeing the first one and thinking, how do I make it look like I'm competent in what I'm talking about here? Because I wasn't quite sure what was going on. So we did a lot of those testings that you had mentioned there. And importantly, the syphilis was done and was negative, because that really does change things. I would say we don't see a lot of AMPI as much as you'd think, but it comes up often enough that you've got to remember a fair bit about it. I would say maybe 10 cases a year type thing, maybe one every month or two. Normally bilateral, men and women similar, can have a prodrome, don't necessarily. Those creamy yellow, white placoid lesions, look, you can get that for sure in syphilitic placoid uveitis. You can get that in macular serpiginous. You can get that when you develop TB type lesions, and you can get that, and it can rapidly worsen in people sort of so-called amphiginous. So you really got to follow these people pretty closely. The bit that I found unusual in this patient was the OCT with the bacillary layer detachment. I haven't seen that before, but it has been reported, and the significant amount of anterior cell I haven't seen before. But, it's been reported. We all talk about the cerebral vasculitis, and you're probably not going to see one, but you might. And certainly we've had a well-known one in Victoria that passed away. I saw a patient at the Austin who came out of ICU about a month after he'd been admitted, said he couldn't see, and was sent down and had an AMPI picture for sure. So you might see it. I guess the important thing I find for these people is ask them about headache. A lot of them will say they have a little bit, but if they're really consistent and definitive about it, you've really got to send that patient to an emergency with the diagnosis written down on a piece of paper, and importantly, write the words on the piece of paper, cerebral vasculitis may die, because otherwise the ED will get it and go, you've been seen by an ophthalmologist, they're not real doctors, have some Panadol, go home. But if you write something, don't write may die, but just write cerebral vasculitis on it, it tends to get him in the department a lot faster. And I know that's a bit glib, but you will face some resistance from our other colleagues because they can't see what you're seeing. So it's important to be an advocate for the patient there. I don't know much about the genetics. I must say I never do those HLAs. I only ever do B27 and A29. So I haven't got anything to say about that.
Ming-Lee, just when we're talking about the unusual presentation of the bacillary detachments in that right eye, obviously we were talking about, does it make you think of other diagnoses? Xavier touched upon this.
So the presence of subretinal fluid in AMPI is a typical feature early on in disease, and so it really depends on when you see the patients as to whether or not they'll have the subretinal fluid. I think it's only about 10% of patients that develop fluid, and that bacillary layer detachment that Xavier mentioned on is commonly associated with AMPI actually, and it's thought to be related to any condition where there is a rapid exudation of fluid underneath the retina can exert a tangential force on the retina, particularly the outer retina. And so as a result of that, it tends to split at its point of inherent weakness, which tends to be the photoreceptor inner segment myod layer. So it gives this appearance of this well-circumscribed cavity, often with hyperreflective material that is within the cavity, and that's the bacillary layer detachment. And very interestingly, there was a recent review published by Bailey Freund's group that looked at the histopathology in about 160 patients, and there were 22 known causes of bacillary layer detachment, so this appearance is certainly not specific for AMPI. And out of the 22 causes, the top two were VKH and AMPI, and that accounted for over 50% of the cases.
Yeah, so that first image, I reckon, I've seen way more VKH patients look like that.
Exactly.
And so when I saw that, this is confusing, which is why we went to the angiogram looking for the hot discs and the multifocal pinpoint leak, which we didn't get.
Interestingly, with this ballad, bacillary layer detachment. The more you look for it, the more you find it. And you can actually see, you see this separation in the photoreceptor layer outer segments where it splits.
When we used to sort of talk about this and say, oh, well, that was fibrin. They were
Yeah.
strands of fibrin, because you'd often see it in these granulomatous type diseases.
And you'll find that in the future, you'll see that there'll be papers written about it in diabetics as well, with severe diabetic macular edema.
It's in AMD, it's in CSC, it's in tumours.
Yeah.
Lots.
Ming Li, you talked about the different ages of the lesions, just looking at the colour photographs. How does the OCT change in terms of disease timing?
So at the start, in the acute phase, the subretinal fluid we've mentioned, but also the focal hyperreflectivity of the outer nuclear layer. So you can see it. It was present in one of the cases before, but certainly the dark area, the outer nuclear layer, appears whiter. And so that's quite a good early sign. And as early as a week after, you lose that. So you can see in that second picture down below that there is now thinning of the outer nuclear layer, there's loss of the subretinal fluid, and thickening of the RPE ellipsoid, the RPE and the interdigitation zone. So very early on, the ellipsoid zone is lost, and that persists for quite a while. And often we think, my goodness, the vision is so terrible, this patient's going to go blind, they're so young. But fortunately, if you wait long enough, often you don't even need to treat them, the outer retina does reconstitute very, very slowly, with complete restoration of the outer retina, with improvement of their visual acuity.
So would you treat that guy?
When there's macular involvement, I commonly do, but again, the jury's out as to what we need to do.
I reckon I almost always do. They've got bad vision, there's that risk of cerebral vasculitis, and once syphilis is off the table, it's very rare that I don't.
Makes you feel better, but again...
Yeah, it makes me feel better, sure, and that's part of the process.
The pathology is thought to be in the choriocapillaris, and now that we've got OCTA, we're able to show that there are flow voids from inflammatory insults that start in the choriocapillaris. They cause ischemia, but the ischemia is transient, and the choroid becomes more perfused. And you can see in that photograph down the bottom, at 6 months, it's completely normal. And interestingly, on the OCT as well, if you look very closely at the choroid, at the acute stages of disease, you can see that the choroid can be thickened, which is in keeping with the pathogenesis.
So on follow-up, just further to what Ming Li was saying, Xavier, what are we seeing here in patient 1?
Well, it's getting better. It's interesting, it's not getting, when we went back to those syphilis ones, they got better a lot faster. This one's taken a bit longer. And you can see that gradual reconstitution of the outer retina. But you can also start to see that RPE is not looking as pristine as you'd otherwise want to see in a 31-year-old. I guess the other reason I like treating these patients is not just the cerebral vasculitis, because you ask people if they've got a headache and they've got vision problem, they almost always say yes, is that some of them can go on to be amphigenous, and then they can just rapidly lose a lot of vision. And so unless there's a strong indication not to give them steroids, such as diabetes, bipolar disorder, a few other things, I pretty much give them steroids. I know that's not great medicine, but you're never going to get a great database for these kind of patients anyway. But yeah, you can see it's reconstituting, but it is taking some time, which is sort of reflective of the significance of the insult. The second thing, which we often ignore, and we now have at the OIC, the immunology clinic at the Eye and Ear, is EDI OCT is mandated for all uveitis patients with macular edema, because we just tend to ignore it. The only time we ever talk about it is when you know the patient's got central serous chorioretinopathy, to then you say, well, the choroid's thickened, because you know that. But it doesn't actually help you. So with these ones, and Lindell, thank you to Lindell for instituting this, you can often use the choroidal thickness as an early surrogate marker of disease recurrence. And so that's something you often don't pay attention to in the midst of all these other findings.
So the one other piece of interesting bit of information about case 1 and 2 was that they were monozygotic twins, and they presented exactly 12 months apart with their AMPI, which we were talking just before about the association, and Xavier was saying it's really unknown at this stage the role of HLA haplotypes in this disease, but certainly this presentation might lend some credence to a year apart some sort of commonality in terms of their genetic predisposition.
Well, it's fascinating, isn't it? They've got these same sort of pattern, and they've ended up in the same, year apart, and they look the same, and everything else is the same. So there's got to be some kind of biochemical reason that they've displayed the same phenotype. I don't know what it is. You could make things up, but it really is a fascinating answer. But yes, I don't do HLAs for any other reason than B27 and A29.
So take-home message is really you need to exclude TB and cerebral vasculitis. We really don't have any genetic information about why these patients are predisposed to this, but certainly the presentation of monozygotic twins with the same disease suggests a commonality in their genetics. This is our final case. You've all done very well to stay. A 30-year-old male with sudden loss of vision in his right eye. He went to his optometrist who told him it was as a result of having long-term migraine with aura and had a negative systems review. He did have a past history of migraine, had a viral episode of viral meningitis as a child, and had bilateral cochlear implants. He was on some Topamax and Sematel for his migraines and naproxen as needed. There's no significant family or past ophthalmic history. Salman, these were his colour photos at presentation. Can you talk us through those?
Yeah, well, obviously I won't mention the retinal arterial findings. He does have some. He does have opacity of the retina, optic nerve head. A retinal pallor, likely to be coagulative necrosis.
And his OCT in the right. How to describe?
There is intraretinal edema. There's hyperreflectivity in the inner retinal layers, although not in that line scan, but elsewhere. There's also change at the pigment epithelial layer, retinal pigment epithelium, with disruption of the outer retina.
And his left eye?
A lesion close to the fovea with subretinal, with findings into the retina at the level of the pigment epithelium and photoreceptor layer. I'm trying not to give too much away.
That's all right. His autofluorescence, are they helpful or are they?
They are certainly very helpful, and I'm sure everyone in the audience knows what this is. There are multiple areas of hyperautofluorescence in the right eye adjacent to the area of hypoautofluorescent, and then there is a hyperautofluorescent area at the left fovea just above it, and some other hypoautofluorescent linear streaks.
And the
There's some inflammation. There is vascular leakage, but from both the patchy vascular leakage from the artery and the vein in the area described, with late hyperfluorescence in the fluorescein angiogram.
And that arterial beating
That's right.
was really odd.
That's pathognomonic of this condition.
Huh.
And here you see late fluorescence, linear streak-like fluorescence in the left eye.
This is the final time I'll call upon you to do an audience poll, if we could get that up. We didn't have a lot of history when he presented, but is this bilateral simultaneous branch artery occlusions? Is this a result of trauma? Are we looking at laser injury? Or is this acute macular neuroretinopathy? If we could go to that poll, please. So half of you are going for laser injury with a third for acute macular neuroretinopathy. So we'll go back to the presentation and I can reveal a little bit more in terms of his history. So once we'd seen his images, we asked him if there was anything we needed to know, and he alleged that 15 years ago, a fellow student shone a laser in his eyes, and that after the initial burst of light, his vision returned to normal, and he'd had no follow-up or problems with his vision ever since then. So really for case 14, the question is he telling the truth? And his follow-up OCD would suggest that he is not. So Salman, can you describe this sort of rapid evolution change that we're seeing at 2 weeks?
I was obviously joking when I was saying that these findings are pathognomonic. I've not seen laser self-abuse like this, and I've seen quite a few laser injuries, but this gentleman takes it to another level. The findings in the right eye are he's obviously lost central vision, and that's allowed him to continue to laser his macula without developing much of a Bell's reflex, although he has, because most of those lesions, they're not branching fractals, they're sort of linear lesions, as he's trying to, as his subconscious is trying to avoid lasering his fovea. And in the left eye, it's clearly a Bell's. He's done remarkably well to recover in the left eye.
So laser-induced retinal injury, so really, as someone was alluding to, the extent of injury depends on the wavelength, the power and the duration of exposure. And we know that from our own therapeutic use of laser that there are 3 mechanisms by which it can induce retinal damage. And that's either photocoagulative, photochemical or photomechanical. And damage occurs at different exposure times and different wavelengths. So the evolution of the OCT findings in this patient in just a very short time, a matter of weeks, suggests that he wasn't telling the truth and he remained in denial about what he had done. He's definitely stuck to the story that the exposure to the laser was 15 years ago. So I have a high index of suspicion in your patients. They don't always tell the truth.
So just the thing that was really odd about this guy, that the story of being held down when he says he was held down and other kids shone a laser into his eye. It's kind of an odd story. They're pretty good aims, if that's true. So that was an odd story. The second thing was he had an artery occlusion. Now, we've all seen a number of laser maculopathies. I have never seen an artery occlusion. So that was really odd. Everything else looked like a laser, but the key to clinching a laser diagnosis is them telling you they shone a laser in their eye. Up until that point, you just are suspicious. And the final thing was, he just wasn't that fast. I can't see.
He was also in his 30s and his mum was with him.
Well, that's okay. It's okay.
No judgment.
Yeah, I don't think we've got a psychiatric illness history out of him. But if you're shining a bright light in your eye, you've got one. We just haven't got a name for it yet. The one thing that this is, so he's an adult and there's not a lot you can do, but it's the kids where this is the problem. You've really got to pester this kid to find out the story of the laser. Where do they get it? Who's got it? Where is it? And get it out of their hands. It's a bit more tricky here, but I can't explain the BRAO. I've not seen that. And, we've shone pretty, a watt at someone's eye, and Ian McAllister is here shone 7 or 8 watts at someone's eye to cause an anastomosis, but I haven't seen an artery shut off. So that's pretty odd. So he's really gone to town on his eye, as Salman said.
Yeah. Interestingly, Trevor Ginn actually saw a woman with a self-inflicted laser injury. I've never seen that before.
We had a woman was actually admitted, I think, and then she did it to one eye and then went home and did it to the other. So your point, Xavier, about finding the laser and getting rid of it.
You've got to get rid of it, especially if they're young kids, because they can just do irreparable damage. And remember, you had those 2 girls who were in a harm pact, and they were, sort of trying to work out who could harm themselves the most. And as you're all aware, we'll bring it up a lot, but the lasers you can buy from Officeworks are limited to 1 milliwatt. You can't buy more than 1 milliwatt legally in Australia. But in preparation for this, I found one you could get with 50,000 milliwatts, and it came in red, green and blue, and it showed you how to use them like lightsabers. And they're sold as a toy, and that was $400. That's the kind of thing you can cut through metal with. So, you're likely to put a hole in your occipital lobe as much as your retina.
So we have 1 minute and 50 seconds to summarise 14 cases. So, Salman, did you want to say something?
Yeah, look, not on this subject. The angiogram meeting was started by Wilson Heriot, and when he was the head of the retina service at the eye hospital, and then continued for 25 years by Alex Harper, who many of you expected to see on the panel. It would be great if he was on there, but he retired as the head of the unit in 2021. And, he's had a contribution that is profound in Victoria. He's taught a generation of doctors, ophthalmologists, retina. And, given the inadequacies of his replacement, it's quite obvious just how good he really is. And I know Alex wouldn't want anything like specifically said that he didn't want to be nominated for a council lecture because he didn't want the stress. So I'm sure that someone could arrange for that to happen.
Can I also point out that most of the time in medical retina, this is what we see. So if you're seeing moderate non-proliferative diabetic retinopathy in people with a big gulp cola in their hand, that's what we're seeing too. These are the once a month type things that we've put together.
We've tried to limit the number of rare birds so that would have some teaching value.
So with that, thank you for all coming. I hope you found it instructive and illustrative. It's been a pleasure. Thanks.